So, Michael, the NHS's 2025 and 26 priorities and operational guidance document is finally out. And as we know, the document addresses how to achieve improvement in waiting times, productivity, and at the same time, also financial stability.
So the document's arrived at last. And I guess the question is how much of it is new. There's kind of much slimmed down list of measures, how much of it's kind of retreading the same ground. And given that we've now only got 18 priorities, are they realistically deliverable, or are we at risk of not learning from the past? And are there any gaps, I suppose?
First, let's look at the priorities and the targets that are associated with elective care. The available published data on elective care shows us, which only dates to November 2024, that all the organisations put together are delivering about 58% against the 18-week target. So the ask is for all these organisations together to reach 65% by March 2026. But individual organisations are also expected to show an improvement by at least 5% against that target. Now, we know that the national target originally was always 92%, and the Labour government have committed to deliver this by summer 2029, really, I guess. But do we have faith in the delivery mechanisms that have been described in the elective reform plan to support this uplift over the next few months, but also indeed all the way up to 2029?
I think that's a really good question. It's interesting when you really dig into the elective reform plan that a lot of the kind of solutions proposed, whether it's community diagnostic centres, CDCs, whether it's straight to test, PIFU, patient-initiated follow-up, and so on, these are things that have been around for a little while now, and they haven't really delivered. Certainly the NHS previously failed to deliver on the ambition of the original elective recovery plan. So unless we can really learn from why those things haven't delivered to date, it's maybe slightly difficult to believe that they're going to deliver such a year-by-year percentage point increase up through until 2029.
You're so right. Learning from what hasn't worked is obviously the best way forward. But let's talk about, I guess, what we understand based on perhaps the work that you do and indeed I do in the space as well. What kind of themes are coming out when you're going into organisations to address elective care problems?
Well, I think maybe starting to unpick some of those reasons why some of these things haven't been as effective as we would like them to have been. Something which often gets overlooked has been the impact of the kind of pandemic and post-pandemic period on staff, both on staff individually, but also on the kind of levels of organisational memory around the management of waiting times and elective care. So some of the kind of fundamental things that we always try and support organisations to implement, good waiting list management, demand and capacity planning, trajectory modelling, and PTL process that we're so familiar with. Some of those things have been, if not forgotten, then certainly kind of devalued. And I think getting back to some of those basics, in addition to the absolutely necessary innovation like CDCs and surgical hubs and so on and so forth, maybe that is kind of part of that balance that we need to actually make the step change that's required to get to the end point in 2029.
Yeah, and I guess those fundamentals are upon which you can build further innovation or further sort of improvements to pathways. How do you feel about the abolition of the elective recovery fund in amongst all of these ambitions?
I think it's complicated, isn't it? On the one hand, it feels like there's an increasing focus on elective care, but then a decreasing commitment to fund it. But on the other hand, the way that the ERF was benchmarked to activity and productivity levels really an increasingly long time ago now is maybe starting to give slightly perverse incentives to the system. And within ICBs, where there's a kind of a pooled amount of money, there are definitely winners and losers under the ERF. I think one thing that we really need to underscore as well is the importance of data quality improvement.
Yeah.
We're all aware of the size of the waiting list nationally and in individual providers, and actually coming back to that, getting the basics right, some of the things around validation, around really understanding your waiting list are so key to making sure that you're targeting resources as effectively as you can. So it's certainly welcome to see in the elective recovery plan that there's this focus on kind of 12-week validation target and revalidating to make sure that you're really got a clear idea about where your bottlenecks are.
But in the vein of learning from what has and hasn't worked in the past, I guess it's important that we don't just do lots of manual validation top down in a chronological order. There is targeted validation, but there's also smarter validation that doesn't require an intensive workforce behind it. And I do hope that we all learn from that. So a glaring gap for me in the current priorities document is the fact that there is no mention of the community mental health waiting time standards that have been talked about for a good couple of years now, with almost over 46,000 service users waiting longer than 2 years, 70% of those being children and young people. It feels really strange, given the focus that we're giving waiting times for physical health, to completely ignore holding systems to account for the same in mental health services.
Yeah, that's right. And I think it does feel like a gap. But I suppose it's important to see the positives in this. Yeah, there is still, where there's been a huge reduction in the number of things being measured and prioritised under the planning guidance, mental health is still in there, doing reasonably well. The mental health investment standard's been preserved. It's good to see that there are the recognition of the importance of reducing length of stay and patient flow through crisis services, and obviously the long-standing commitment to reduction of inpatient beds for people with learning disabilities. And autism is really important. But as you said, the waiting times thing feels like a bit of a gap. NHS England made a really positive move last year's planning guidance with defining what a kind of metric around mental health waiting times would look like, and setting an initial expectation that people improve their data quality and reduce the reported number of people waiting for more than 104 weeks. But really, in only looking at crisis and inpatient services and not looking at community services, you're kind of only seeing half of the picture. We all know that people deteriorate when they're waiting longer, and that those people, as they deteriorate, are then more likely to present in crisis and to be in those very inpatient beds that we're trying to reduce. So it does kind of feel like a bit of a unbalanced way of approaching the broader system issue in mental health. So moving away from elective care, I guess one of the other big pushes in the planning guidance is around digital transformation and innovation. And this is something that's been rattling around for years as well. And I suppose a kind of warming to our theme of what are we going to learn from the past and what are we going to do differently next. It'd be great to hear kind of some of the barriers and some of the reasons why maybe digital transformation hasn't happened at the pace that we might like so far.
Yeah, sure. I mean, we have a great ecosystem of innovation. There are 15 health innovation networks that are putting some great companies, great innovators through programs year on year. The challenge, certainly from being one of those people, but also really talking to a lot of similar founders out there, the challenge is the update, as you rightly picked up. There are procurement barriers, there's cultural resistance, and generally there is a scaling challenge. My biggest question, not just to the NHS, but indeed to the government, is how are the smaller companies who are coming up with niche innovations for the NHS to save it money, to make improvements for patient outcomes, how are they being brought to the table? Whenever we hear about a round table happening, organised by the government to talk about how do we improve the NHS, it's always the big players on the table. And I guess the question for me is that stifling innovation? So we are at a crossroads in the NHS. We have far fewer priorities in this document, which should mean sharper focus. But without learning from our past, bold action on implementation and innovation adoption, do you think progress will be slow?
That's the right question to ask, Karina, because simplifying the planning guidance and reducing the number of priorities is welcomed by systems, but on the other hand, just setting targets and setting expectations is not the same as delivering outcomes and providing support. Given the situation with NHS England at the moment, the national support offer is more challenged than it's ever been, and I think we have to really ask the question, who is there to support providers, who is there to support some of the healthcare leaders that we work with in our work, whether it's in physical health or in mental health, and who's there to support and develop the staff who are going to be needed on the ground to deliver a lot of these changes.
That's a great insight, Michael. Thank you for your time today and talking to me about all things planning guidance.
It's good to chat to you about these things, Karina. Looking forward to getting stuck in with some of the work that needs to be done.
Me too.